So welcome to PsiAN and our latest installment in our Forum Live events. I'm Linda Michaels, the chair and co-founder of Psychotherapy Action Network, and along with co-founder Janice Muir and Erica Schmidt and our board of directors, I'm really delighted to welcome our esteemed panelists and to welcome all of you. I'm just going to say a few words about PsiAN before we get started. As many of you know, PsiAN is a grassroots nonprofit focused on advocating for therapies of depth, insight, and relationship that create lasting change. As we like to call them, therapies that stick. We're committed to changing the public narrative about therapy, empowering professionals to stick up for the treatments they provide, and supporting policies that advance access to the healing and growth we have to offer. Our big tent has room for everyone, so all disciplines, psychology, psychiatry, social work, marriage, family, research, and all theoretical orientations. We're 5.5 years old and we've grown tremendously, and we now include nearly 5,000 individual members and over 80 organizational members. This program today is so exciting. And again, we're bringing together a multidisciplinary group of experts, not only from the therapy world, but also the medical professions, to delve into this issue, this amazing, confounding, perplexing, sometimes painful reality of having a mind and a body. And the many ways the mind and body connect, sometimes conflict, and communicate with and for each other. Our next Forum Live will take place in January and will focus on issues of insurance denials and parity. And we'll have another incredible panel of experts, as well as a toolkit of sample appeal letters and other materials you can use. If you appreciate our events and all of the advocacy we do, we'd love to hear from you. And we'd also love for you to contribute to our annual appeal, which just launched earlier this week. You can go to our website, PsiAN.org, and donate there. And please know we do all of this on a pro bono basis, and we're unbelievably, ridiculously frugal. So you can rest assured that every dollar you donate will make a difference. Now, back to tonight's event. This event could not be possible without Becca Butler in the wings. Becca is a member of the PsiAN communications team in her 4th year working towards her PsyD at Antioch, New England. And she joined PsiAN because the more clinical experience she gains, the more she understands the deep importance of those therapeutic relationships. And she's in Boston. She moved there to intern at a community clinic, working with individuals and youth of color. And now she's at Clark University's Counseling Center. And now I'm delighted to introduce our moderator, Bevan Campbell. Bevan is a psychologist treating couples and individuals in Brooklyn. Dr. Campbell has a postgraduate certificate in couples therapy from Adelphi and is an advanced candidate at the William Allenson White Institute. She teaches graduate students at NYU and PACE and is a clinical supervisor at Long Island University and PACE as well. She is the creator and host of the PsiAN Forum Live, our quarterly forum on issues impacting contemporary mental health care, as part of her work with PsiAN. Bevan's also a consultant with the Academy of Community Behavioral Health, which is a partnership between the mayor's office and the CUNY School of Professional Studies, where she designs and facilitates coursework on responding to grief and loss. So thank you all so much for being here today. Now take it away, Bevan.
Thank you, Linda. I'm really excited to be here, and I'm very excited for this event. I'm going to say just a few words of introduction before our panelists talk, and then I'll give you a little overview of what the format of this event. But before I do, Becca is actually going to launch a few polls just to sort of get a sense of people's familiarity with this topic. So in the first one, you'll see up there, have you used depth therapy? And again, by that, we broadly mean psychoanalytic, existential, humanistic, to treat chronic pain and or psychophysiologic or mind-body disorders, maybe migraines, IBS, and fibromyalgia. So we'll leave that up for a moment. And then and Becca's going to launch another one in a moment while I'm talking, and then we'll talk about those results. So Linda actually came up with the idea for this forum, and I think one of the reasons that we wanted to do this is because, as many of you know, PsiAN undertook a large research project regarding the public's perception of mental health treatment in general, and in particular depth therapy. And one finding I thought was very interesting was that for a large number of people we spoke to, their first step in finding psychological treatment is or would be their primary care doctor. And I take from this finding two things. One, that clearly healthcare professionals have enormous influence in determining what types of psychological treatment people end up receiving. And two, that physical symptoms can be, for many people, where suffering registers most acutely, and is for them the gateway into addressing associated emotional and psychological issues. So where does depth therapy fit into the landscape of treatments for mind-body symptoms and chronic pain? Based on my experience, what I've seen, physical symptoms, even those widely accepted to have a psychological component, are most often treated with medical interventions or perhaps brief behavioral psychological interventions that focus on symptom management. And the irony of this, of course, is that our work, depth therapy, was born from the discovery that talking about difficult, painful, and unacceptable thoughts and feelings could relieve medically unexplained symptoms. The term talking cure, as I'm sure everyone here knows, was famously coined by Bertha Poppenheim, or as she's known by her pseudonym, Anna O, who was treated for symptoms such as severe cough, paralysis of the extremities on the right side of her body, and disturbances of vision, hearing, and speech. So to ask my previous question a different way, how should depth therapy fit into the landscape of treatments for mind-body symptoms and chronic pain? We're going to be hearing from some very esteemed panelists on this topic, which, as you will hear, has a personal resonance for many of them. And I just want to say one thing that is interesting to me is I actually learned about the work of many of these people here, not through the field, even though I'm a psychologist, but through my mother-in-law, who I believe is watching right now with my children, based on her own search for, understanding these issues better. And she's a layperson, but she sort of introduced me to many of the panelists here tonight. So I think that's a common story. A lot of people find their way into this world out of necessity. So let me tell you the format. So we're going to hear briefly from each of our panelists. They're going to talk a little bit about the topic, our theme for tonight. And then I'm going to ask a few questions of the panel. We'll have a discussion, but I do want to save a lot of time for a Q&A. We have a lot of attendees right now. I'm sure people will have many questions. At any time during the event, you can put your question in the Q&A. If it's directed to a particular panelist, please just indicate that in your question, and I will read the questions at the end. So before I introduce our first panelist, can we launch our poll results, Becca? Okay, so we are about 50-50 yes and no, as you can see, if you've used depth therapy to treat chronic pain and or mind-body disorders. So about 52% of people saying yes. Thank you, Becca. And the next poll, yes. So 97, almost everyone who has responded, 97% is saying we do encounter patients with somatic symptoms without a clear medical cause in our clinical practice. Okay. Thank you so much. I'm going to introduce our first panelist, Frances Somer Anderson. The body, disabled, disfigured, in pain, has been the focus of Fran's professional work since she did her clinical psychology internship at Rusk Institute of Rehabilitation, NYU Langone Medical Center in 1974. Invited to join the staff of the psychology department the next year, she treated children and adults with progressive neuromuscular disease. In 1979, she was invited to work under the supervision of Arlene Feinblatt, PhD, the psychologist who helped John Sarno, MD, develop his theory about the connection between emotions and musculoskeletal pain. In 1987, Fran left Rusk Institute for full-time private practice treating chronic pain and psychoanalytic training at the NYU postdoctoral program in psychotherapy and psychoanalysis. Influenced by the developing relational school of psychoanalysis while in psychoanalytic training, she was invited by the late Lewis Aaron to co-edit a groundbreaking collection of essays, Relational Perspectives on the Body, bringing the body into relational psychoanalytic theory. In 2008, she edited Bodies in Treatment, The Unspoken Dimension. She co-authored Pathways to Pain Relief with Eric Sherman, PsyD, in 2013. She was the invited lecturer at the 22nd John Bowlby Memorial Conference, London, UK, in 2015. In collaboration with cognitive neuroscientists Richard Lane and Ryan Smith, she published a theoretical model to explain how physical pain can override emotional pain. She taught a course on treating chronic pain for the faculty of the Certificate Program in Trauma Studies at the Manhattan Institute for Psychoanalysis in NYC, where Fran is a member of the CPTS faculty. Fran is recognized internationally for her experiential teaching style and her integration of the neuroscience of attachment, pain, and trauma with relational psychoanalysis. Affirming in publications that affect regulation is a primary interest, Fran acknowledges the affect regulation she has received from generations of felines. She is currently sustained on a daily basis by her attachment to her 2 orange male tabby cats, Mango and Papaya. Amazing names. I'm going to turn it over to Fran.
Thank you, Bevan. I am happy to participate in the panel. And as you heard already, I got started in the field as a psychology intern at Rusk, and I stayed on until 1987. And it was there that I became interested in working with chronic pain with Dr. Sarno and Dr. Feinblatt. And while I was working mostly successful with Dr. Sarno's patients, I developed a physical symptom myself, which was very embarrassing, chronic headaches. And that led me later to have to take a deeper dive into my own history of trauma. And that's been very enlightening in my work with my patients. Once I entered psychoanalytic training at the NYU postdoctoral program and started to discuss my patients in chronic pain in seminars and with consultants, I became passionate about teaching mental health professionals how to treat pain. So this was I began analytic training in 1989. And at that time, psychoanalysts who I presented to were not that open about chronic pain having an emotional component. Thanks to studying with Dr. Joyce McDougall, who supported me in writing about my work with Dr. Sarno's patients, I was able gradually to get more and more information out to psychoanalysts about empowering them to learn how to treat chronic pain. And the secret of that is education, educating the clinician, mental health clinician, about the neuroscience of pain and how the body works. And I also was highly motivated to co-author with my NYU postdoc colleague, Dr. Eric Sherman, who also worked with Dr. Sarno, a book of case studies on how we treated Dr. Sarno's patients, and that's Pathways to Pain Relief. As the field of neuroscience developed very rapidly, it brought new understanding of the impact of emotional and physical trauma on the development of chronic pain. And I began to integrate this knowledge into my treatment approach. And following one of my mentors, Will Nobuchi, I would say that our psychological models need to be congruent with the research in neuroscience to correspond to how the brain actually works. I acquired new tools for accessing nonverbal somatic processes when I took Peter Levine's somatic experiencing training, and I benefited from that greatly. And I'm currently focusing on the impact of early life adversity on the development of chronic pain later in life. Thank you.
Thank you so much, Fran. And I'm going to introduce our next panelist. So our next speaker is David Clark, MD. Dave is the president of the Psychophysiologic Disorders Association. He is also assistant director at the Center for Ethics and clinical assistant professor of gastroenterology emeritus at both Oregon Health and Science University in Portland, Oregon. He is board certified in gastroenterology and internal medicine and practiced gastroenterology in Portland from 1984 to 2009. During that time, he successfully treated over 7,000 patients whose pain or other symptoms were not explained by diagnostic tests. The ideas are described in his book, They Can't Find Anything Wrong, which was praised by a president of the American Psychosomatic Society as truly remarkable and named by Brit & Co. to be one of the 5 best mind-body books ever written. He is also the lead editor for the professional textbook Psychophysiologic Disorders. He lectures about psychophysiologic disorders to healthcare professionals and the public across North America and in Europe, and appeared in over 100 television and radio broadcasts. The PPD Association website is endchronicpain.org. I will put that in the chat, and thank you, Dave.
Thank you, Bevan, and thank you, PsiAN, for hosting this meeting tonight. It's a great opportunity to share some ideas. I like to present a patient who was personally meaningful to me. As a woman who was 50 years old, I was asked to see when I was still early in my experience in this field in the 1980s. And she was admitted to the hospital with an attack of extreme dizziness accompanied by nausea and vomiting. And when I went to see her, she said something to me that I'd never heard from any other patient before then, or since then for that matter, which was, thank you very much for coming, Dr. Clark, but don't waste your time with me. You'd be better off seeing your other patients. And I asked her why she felt this way, and she had good reason, because she lived, I changed the details of this story in my book, but the real patient lived in Palo Alto and had been hospitalized at Stanford for exactly the same symptoms, a total of about 60 times over the previous 15 years, roughly 4 times a year. And of course, with all those hospitalizations, she'd had every test you can think of. She'd seen a dozen specialists in a variety of different disciplines, and eventually a psychiatrist who determined that she had no mental health diagnosis, but also completely missed the fact that she had a psychological reason for her numerous attacks of symptoms. And to make a long story short, what those turned out to be is that she had a verbally and emotionally abusive mother, and her attacks of illness always occurred in conjunction with interactions with the mother. The most telling of these was that she would always get one of her attacks of illness whenever she passed through a little town about 45 minutes from where she lived. But it turned out the only time she ever had occasion to pass through that community was when she was on her way to visit her mother, who lived several hours further down the road. And so what was happening was she would be building up enormous emotional tension while driving down the road to visit her mom. And when she passed, by the time she got to this town, it was manifesting itself physically. And when I asked her if she could drive 45 minutes in some other direction and whether she would get symptoms in doing that, she recognized that it didn't matter where she was going as long as she wasn't going to visit her mother. She could drive an hour and 45 minutes as long as she wasn't going to visit her mother, and she would have no symptoms. And a lot of her symptoms also occurred after she would speak with her mother on the phone. And in her case, just having this realization, just having this conscious recognition of this connection between her mother and her symptoms, which had not been recognized before, which is all too typical for these patients not to have conscious awareness of the psychosocial stresses that are responsible for their symptoms. In her case, just making her aware was enough to alleviate her condition. She went home from the hospital and she called me a year later to say she'd gone the entire year without a single attack. And it just, was very striking to me that an institution like Stanford, with all of their specialists and their psychiatrists, could have missed this. And it illustrated a number of features that are common in this population, which is number one, that there can be very powerful buried emotions in these patients that they're not consciously aware of. Number two, there can be triggers in the present day that are linked to past mistreatment or traumas that can lead to symptoms. And number three, which I haven't mentioned about her, but there can be personality traits that can be very stressful for these patients, yet that are amenable to treatment. And in her case, low self-esteem, perfectionism, and excessive self-criticism, all linked to having been continuously verbally and emotionally abused as a girl, but again, very amenable to therapeutic intervention. This is a population of patients that presents themselves typically to the medical profession. 40% of primary care patients have conditions like this, but the medical clinicians are not comfortable evaluating it, and most mental health professionals are not comfortable with patients who are physically ill. So what we end up with is 40 million people that have a mental health disorder that is not being addressed. It's the single largest blind spot in the healthcare system. And it's relatively straightforward for experienced mental health professionals to graft the knowledge and skills of dealing with this population onto what they already know. I've taught hundreds of graduate students who, as part of their course, evaluate and treat a patient with this condition. And they're able to do it with just reading a couple of textbooks and having some webinars, which are, by the way, replicated on the webinar course on the endchronicpain.org website. So for someone who's already experienced in psychological evaluation and treatment, it's not a huge challenge to take these patients on, and it's very rewarding work to see how dramatically many of them can turn their situations around.
Thank you so much, Dave. And before I introduce our next panelist, I want to say someone asked in the chat about paper recommendations, and I know that I'll address that with the panel later, but I also want to mention that Jeff Axelrod was kind enough to offer a resource list. So after the event, we'll be distributing that, and so that I'll have some more information about reading, some of which will be referenced tonight. I'm very excited to introduce our next panelist, and I'm particularly excited because we don't get a chance to, kind of connect interdisciplinarily on these forums. And I know that for many people who are struggling with a physical issue or in pain, a therapist isn't probably going to be their first call. They're probably going to actually connect with someone like Jerry. So Jerry Pierre is a registered dietitian, nutritionist, and certified diabetes care and education specialist with over 25 years of experience in healthcare. She's passionate about helping people achieve optimal health by creating and practicing lifestyle habits to prevent chronic illness. Throughout her career working in hospitals, schools, and clinics with people of all ages, she has educated patients and clients on improving their health by addressing risk factors they can control, like food choices and physical activity. In her current role as lead health coach with Trestle Tree, she empowers participants with a combination of implementing behavior change principles and providing education. She believes in a holistic approach to health that includes taking care of the physical, mental, and social emotional aspects. In her free time, Jerry enjoys experimenting with new recipes, spending time in nature, practicing yoga, and dancing. She serves as the technology chair of the New Jersey coordinating body of the American Association of Diabetes Care and Education Specialists. And thank you so much, Jerry. I'll turn it over to you.
Thank you so much, Bevan, and thanks everyone for having me and for coming. I'm excited to see that there's so many practitioners who are wanting to improve the lives of patients and ourselves, dealing with mind-body issues, chronic pain, and the emotional components of pain. I will talk about my personal experience and my professional experience. First, starting off with my personal experience, I first started in childhood, as I look back on it, probably with mind-body symptoms, not knowing that, of course. But I always had like stomach aches, or was the last person at the dinner table because I didn't want to eat anymore because my stomach was hurting, and just really didn't have any ideas at that time that this could be emotionally related. I do have an extensive trauma history, which I've since learned with the work with my therapist that this can connect with chronic pain. Throughout my adulthood, I've had several, which what feels like to me a very long list of mind-body experiences, including mouth sores, allergies, irritable bowel syndrome, plantar fasciitis in both feet, bilateral patellofemoral syndrome, so knee pain in both knees with no real explanation for a physical problem, eczema of my lips, eczema of my hair follicles on the feet, legs and arms. And one of the ways that became very clear to me, the clearest sign of the emotional component of any of these conditions, is stiff neck and pain. And at one point, it was so bad for at least a week, and I didn't know what I was going to do with myself. And so much so that turning my head to the right caused nausea and pain and stiffness. And one night, I just let emotions go and was grieving a difficult relationship, and sadness, and it just all came out. And the next day, the pain was gone. No more nausea, no more stiffness. And as frustrating as it is to know that there's nothing wrong physically, it's also amazing to know that these emotions and traumas and suppressed emotions can cause such physical manifestations that would make you think that there's something wrong and somebody needs to figure it out, or what am I going to do about it? So luckily for me, I started therapy in the last year of college. And so at that time, finances weren't an issue. And I just walked into the student center and was able to connect with someone. And after that, I've had the fortune of working with therapists who would work with me financially, because as many of the people here know, there's the insurance issues and access that way. Additional challenges to getting the help that someone needs are social. So growing up, the messaging that I heard was crazy people need therapy. That was one. And the other is that you don't tell family business, right? So there's the protection of what's going on. I came from an immigrant background. My parents are from Haiti, and I've seen personally and professionally that a lot of people there, especially immigrants, they're in survival mode. They're working 2 or 3 jobs, or just the idea of stress is completely foreign. And there may not even be a word that translates to that. I remember my mother, as I was younger, in Creole saying, "Tête moi chargée," which means my head is full. And so now as an adult, I can realize that means that she was overwhelmed and she was stressed. And she had mind-body conditions. She was diagnosed with fibromyalgia. She also had a herniated disc that she had surgery. And of course, that did not help her pain at all. And that was in the 80s and 90s, and nobody was talking about emotions and trauma and the connection to physical pain as well. Additionally, other challenges that come with people connecting to therapy is diversity. Many people want to walk in and feel that the person that they're talking to understands where they're coming from, or that they don't have to educate the person on some of the issues, whether it be race, religion, gender. People want to feel that connection. And the research shows that there's 4% of therapists are Black, another 4% are Asian, 6% are Hispanic, and 2% are Indigenous. So that's another challenge. I think it's surmountable. I haven't necessarily had therapists that were the same background, but everyone's different. And in my work with my clients, there's a lot of fear. People who I work with who encourage their own children or other family members to go to therapy, when I bring it up to them as when they're talking about their pain that might be having, that all of a sudden their back is hurting or they're having GI issues. And we talk about stress. So one of the wonderful things about the work that I do is that I don't just talk about food and exercise. I get to hear about what else is going on in people's lives, the stressors that they have, whether they call them stressors or not, as well as challenges. And I can, obviously, I'm not a psychiatrist or psychologist, I'm not diagnosing, but I hear things that make me recognize things that I experienced, and also just from reading and understanding that there's a connection there. And when I say, well, why not talk to someone? There's the fear of vulnerability, of not knowing, of the unknown, being afraid, like, well, what am I going to say? Or the lack of trust. And also people thinking, well, their problems aren't that bad. And so it's, talking like, well, we don't need it to get so bad for you to get help. Like, it's okay to start addressing certain things there. So in my role as a health coach, as a healthcare practitioner, as a Haitian American who wants people to understand the value of therapy and how life-changing it can be in terms of improving your health, both physical and mental health. If your mental health is better and that's affecting your physical health, then you can play with your kids, then you can do the jobs that you want to do. So my hope is that having these continuous conversations with people and planting that seed will get them closer to coming to see many of you who can help them with their health challenges. Thank you.
Thank you so much, Jerry. That was really great. Someone in the chat thanked you for sharing your personal experience, and I'm sure a lot of people are echoing that appreciation. Let me introduce our next panelist. So Dr. Howard Schubner is an internist and the director of the Mind-Body Medicine Center at Ascension Providence Hospital in Southfield, Michigan. He achieved the rank of full professor at Wayne State University School of Medicine and is now a clinical professor at the Michigan State University College of Human Medicine. He has conducted groundbreaking research in the field of nociplastic pain and has authored more than 100 publications in scientific journals and books and lectures regionally, nationally, and internationally. Dr. Schubner is the author of 3 books, Unlearn Your Pain, Unlearn Your Anxiety and Depression, and Hidden from View, written with Dr. Alan Abbas. He is a co-editor of 2 other books, Psychophysiologic Disorders, Trauma-Informed Interprofessional Diagnosis and Treatment, and A Guide to the Diagnosis of Psychophysiologic Disorders. Dr. Schubner lives in the Detroit area with his wife of 39 years and has 2 adult children. Thank you so much, Howard.
Thank you, Bevan. Thanks for having me here. Just to kind of piggyback on a couple of statistics Dave Clark had, roughly 50% of the people who are seeking counseling for anxiety or depression will have a chronic pain or other mind-body type condition, 50%. And 90% roughly of the people who have chronic pain have a mind-body or nociplastic or neural circuit condition. So, the people who should be treating these, the physicians, as Dave pointed out, the physicians are having trouble diagnosing and taking time and talking to people. But therapists also are gonna have to be, I think, the key, the cornerstone of treating folks for this disorder. And I wanted to make just 3 points. The first point is that pain is an emotion. In my simple-minded viewpoint, an emotion is something that is a response that's activated in the body by a subconscious act to something that happens in the brain. So something happens in the brain, some kind of hurt, some kind of issue, some kind of remembrance, some kind of anniversary, some kind of near traumatic experience, being, a car coming toward you, anything can activate a physical response in the body. And that physical response, therefore, can be pain, anxiety, fatigue, blushing, tears, anger, dizziness and vomiting, like Dave's patient was talking about, obviously some of the things that Jerry was talking about. And so pain is actually an emotion, and all pain is generated by the brain. And even an injury doesn't necessarily cause pain. An injury will send signals to the brain, but the brain has to decide, this is a weird concept, has to decide whether to activate pain or not. So number one, pain is an emotion. Number two, the treatment of pain first requires recognizing that it's not a structural medical problem that needs treatment, which in chronic situations, as I mentioned, is only roughly about 10% of the time, depending on the syndrome. And then secondly, addressing the underlying issues. The other thing that physicians need to be able to do is help people realize that the cause of their symptoms are not chronic Lyme disease or Ehlers-Danlos syndrome or mold or mast cell activation syndrome, or a lot of things that people are told are the cause of their pain that are actually not. But then your job, and I've had to learn to become a therapist over the last 20 years because I didn't have therapists that I could refer to in Detroit, in my area, who were actually doing this work. And so then the treatment becomes, one, addressing the underlying emotions. One, the underlying emotions related to the pain, so the fear of the pain, the worry about the pain, the focus on the pain. And we do that by what we're now calling pain reprocessing therapy, which has to do with simply helping the brain to feel safer, to feel reassured, helping their brain to feel empowered, helping their brain to be connected, to be joyful, to be compassionate. All those things turn off the danger alarm mechanism of the brain, which is causing pain or other symptoms such as chronic fatigue, anxiety, depression, et cetera. And I think of anxiety and depression in the same as just different manifestations of this underlying danger and alarm mechanism. And some people may disagree with me. The second way we treat it is actually dealing with the underlying emotions related to the stressful life events, past or present. And the models that I've been using, they're certainly not the only models, but the models that I've been using over the years has been intensive short-term dynamic psychotherapies. Our version of that, Mark Lumley and I developed emotional awareness and expression therapy, which was a simpler version of ISTDP, which we could comprehend and we could practice, which we used in a couple randomized controlled trials that we'll send you the links to, that these studies. One of our studies was the first study to show that emotional awareness and expression therapy was superior to cognitive behavioral therapy in the treatment of fibromyalgia. Brandon Yarnes replicated that study. And I'm also been using a lot of techniques from internal family systems, which jives really well with our model. And so what we're doing is helping to deal with the actual trauma using memory reconsolidation techniques and accessing emotions that have been avoided and unrecognized, as Dave pointed out. And the third thing I want to say is that pain and these other symptoms are an emotion, but they're also a message. They're a guide. They're the brain's alarm mechanism, like a smoke alarm, saying that something is amiss in this person's life. And because of that, the pain is not actually the problem. The pain is the solution the brain has come up with. The brain can't tap you on the shoulder and say, by the way, there's something amiss in your life. It gives you all these symptoms, such as Jerry was talking about. And it's up to us to recognize them. But ultimately, the pain is a message. And ultimately, it's a gift because it's alerting us to something that we need to do, changes we need to make in our lives, things that we need to address, and help us become the person that we can be. So that's what I wanted to say.
Thank you so much, Howard. And I wanted to mention for anyone who's interested of seeing more of Howard in action or working with patients, you can check out the film This Might Hurt. It's great. I just watched it this week and you'll get a very good sense of how he works with people. I also wanted to remind people at any time, please put a question in the Q&A and we will come back to them. Okay, I'm going to introduce our final panelist. Jeff Axelbank, PsyD, is a psychologist working for over 25 years in both clinical and organizational consulting roles. As a psychotherapist, he provides individual and group therapy, specializing in complex trauma and chronic pain. As a consultant, he focuses on underlying dynamics which might not be obvious when looking at the surface. In particular, Dr. Axelbank utilizes large group whole system interventions involving multiple stakeholder groups, using methods such as future search to address issues such as conflict resolution, strategic planning, burnout and morale, organizational culture, and change management. Jeff was named 2011 Psychologist of the Year by the New Jersey Psychological Association and was awarded the prestigious Peterson Prize in 2013 by the Rutgers University Graduate School of Applied and Professional Psychology for outstanding contributions to professional psychology. Jeff currently serves as treasurer on the board of the International Society for the Psychoanalytic Study of Organizations. Thank you so much for joining us, Jeff.
Thank you. I'm thrilled to be here. I feel a little humbled to be on the same panel with my fellow panelists. Howard just mentioned something which I want to focus on, which is that the approaches we are talking about have been shown to be more effective than CBT, and raises the question of why. And I think it's also a similar question as to why people who have been in psychodynamic therapy sometimes also are not helped with their chronic pain. I have a lot of people come to me and say, well, I've already been through therapy. I've already touched on my trauma. I already have dealt with that, but I'm still in pain. So I think it goes back to a basic foundational stance, maybe not even related to the difference between CBT and psychodynamic approaches. I think the problem flows from the idea of quote unquote pain management. When you talk to most people, most psychotherapists, most doctors, mostly anyone about treatment of pain, pretty much everyone refers to it as pain management. It's just what's in the culture. If you have pain, it's got to be managed, coped with. And there's all kinds of research that says being in pain is bad. It affects people in all sorts of ways, including mental health. But the minute that you say pain management, there is an implicit assumption that the pain is a given and has to be managed, that that's the best we can do. In most situations we've been talking about, this is simply not true. So calling it pain management actually sets quite a low bar for the goals of treatment, and I would say guarantees that the pain will persist. You're telling the conscious mind that you just have to learn to live with the pain. And you are implicitly telling the unconscious mind that the pain is due to a physical problem, and that creating the pain as a distraction is actually working. So getting back to the question of why CBT doesn't work as well, I think it's because CBT is basically pain management. It still reinforces the idea that there is something wrong with the body. Whenever someone comes to you with chronic pain and they're asking for pain management, or even if they say they're going to someone else for pain management, I would urge you to correct them. It's that what we do is aimed at pain cure, pain elimination, stopping the pain, and perhaps explain the difference, that calling it pain management is going to limit them. Of course, this assumes that you've ruled out structural causes and diseases and confirmed that the situation is a psychophysiologic disorder. So this brings up another question. What about cases where our approach doesn't seem to work to achieve this lofty goal of stopping the pain? What are the limitations of our methods and theories? And so it reminds me of a case I had when I first started to do this work. I got a referral from someone I got a referral for someone who was housebound, in fact, was confined to bed. And I agreed to see them at their home with the understanding that the goal would be to help them enough to be able to come to my office. I was filled with optimism of the power of this approach. So there I was, sitting in this person's bedroom at the bedside. They're laying in bed, and they were morbidly obese with clearly very limited mobility. And in taking a history, I learned that this person's mother had hit them in the head and elsewhere with a cast iron frying pan. Well, I took this case to my supervision group, and I remember the supervisor saying to me, "Jeff, remember, you're a therapist." And I think I was so focused on this person's pain and helping to end it that I lost sight that first I needed to establish a relationship, and that some people's trauma is so severe that the pain is actually secondary to dealing with that. But I think it goes even further. It's not that the pain is secondary to the trauma, but that the pain is actually preferable to facing the trauma. Not on the conscious level, of course, but on a deeply unconscious level. And in these cases, I think we have to remember that we are therapists, and the treatment goes back to just what I call sort of regular old therapy. And the way I think about this is that our job becomes helping the person to become stronger, to have greater tolerance for their emotional pain, to deal with whatever trauma has been in their lives. And only then will it be possible to start to help them see how the pain is a distraction from the things they don't want to think or feel about. There's a great example of this, I think, in the film that we just mentioned, This Might Hurt, which I would actually also urge everyone to watch. There's a patient followed in the movie, Tony, who does extremely well in Howard's group, becoming essentially pain-free in the 4-week program. But at the 1-year follow-up, it turns out that he suffered a major relapse, probably at least partly as a result of another trauma in his life. But the glaring question is, why didn't he call Howard and ask for help to get him through that and get him back on track? So my take as an observer, obviously having no direct contact with Tony, is that the pain is a way for him to avoid separating from his mother. I think when you see the movie, you will recognize the signs of that. So that would be a case where the treatment would have to shift from a focus on the pain to regular old depth therapy to help this young man with separation issues. And then the pain can be dealt with. In my supervision consultation group that I have, which focuses on psychophysiologic disorders and chronic pain, we've noticed how many of the cases the members present involve separation issues, for example. And this is especially true in my experience when pain reprocessing therapy has been tried and it doesn't seem to work. And so the therapy really needs to pay attention to these dynamics when the pain doesn't seem to respond to the approaches which we have talked about here. Another situation, it's somewhat funny, I think, as I've come across, is someone coming to me that has a pending lawsuit from, say, a car accident or a slip and fall. They want to become pain-free, but they are in a lawsuit where they want compensation for their pain. And in these cases, I've put to them very clearly at the outset the question, do you want to be pain-free or do you want to win your lawsuit? Because I'm not sure you can do both. And in pretty much every case, people have said, no, thanks, I'd rather win the lawsuit. I'll come back to you after that is settled to work on my pain. And I can say none of them have ever come back. So thank you.